Welcome to the Weekly Neurology Deep Dive. I am your host, and I am joined by my co-host to guide you through some of the most essential literature in our field today.
It is wonderful to be here. We have a truly fundamental topic lined up for everyone.
We really do. But before we get into all the details, I want to acknowledge that this program is produced by Amer Gavanini.
And we must emphasize our standard disclaimers. This deep dive is strictly for educational purposes.
Exactly. There is absolutely no commercial goal here. And please remember that what we are providing is just a summary. You are highly recommended to read the full paper yourself.
That paper, strictly speaking, is titled Abnormal Spontaneous Electromyographic Activity by authors Long Davalos, Kapil Arya, and Hani Kushlaf.
It is an outstanding paper. We know you are all busy neurologists, perhaps listening to this on your commute or between consults. So let us start with the executive summary.
The absolute core takeaway is that silence is golden. Under normal physiological conditions, skeletal muscle should be completely electrically silent.
Outside the end plate zone, of course.
Precisely outside the end plate zone. And the threshold to remember is 3 seconds. If you insert the needle and the activity persists for longer than 3 seconds, you are looking at an abnormal finding.
And beyond just looking, this paper emphasizes listening. The auditory components of the EMG are crucial. The authors provide what is essentially an audio cheat sheet to help differentiate neurogenic from myopathic disorders.
I love the auditory metaphors in electromyography. They are, incredibly distinct.
Run through the major ones for us, just to set the stage.
Certainly. If you hear a sound like rain on the roof, you are dealing with fibrillation potentials. If it sounds more like popcorn popping or large raindrops on a tin roof, those are fasciculations.
Then we have the mechanical sounds.
Correct. A jackhammer or a misfiring motorboat points to complex repetitive discharges. The classic dive bomber sound indicates myotonic discharges.
What about the rhythmic ones?
The sound of marching in unison tells you it is myokymic discharges. And finally, a high-pitched pinging sound is characteristic of neuromyotonic discharges.
That is a fantastic scaffold for the rest of our discussion. So let us go deep into the first category, the bedrock of the abnormal exam, which is the fibrillation potential. The rain on the roof.
As we established, the baseline should be quiet. Fibrillations are spontaneous action potentials generated by individual muscle fibers that have somehow lost their innervation.
The paper is very careful to point out the pathophysiology. It is not exclusively denervation, is it?
Most of the time it is denervation. However, it can also occur if a fiber is sectioned transversely or longitudinally, or even in regenerating fibers. The fundamental issue is that the fiber membrane becomes hypersensitive.
So it fires on its own.
Exactly. It fires spontaneously, and it typically does so at a very regular rate, anywhere from 0.5 to 15 hertz.
Visually, these are usually triphasic or biphasic. But there's a crucial morphological detail the paper highlights. It is the initial deflection.
This is a detail that really separates a novice from an experienced clinician. A true fibrillation potential must have an initial positive deflection.
And by convention in electromyography, a positive deflection means the waveform goes downward on the screen first.
Correct. That initial downward phase lasts about 1 to 5 milliseconds, and it is followed by a much more prolonged negative phase.
Why is that initial positive deflection so critical to identify?
Because if you see an initial negative deflection, which goes upward, you are almost certainly not looking at a fibrillation. You are likely in the end plate zone looking at end plate spikes.
Which are entirely normal physiological findings.
Precisely. And confusing the two can lead to a cascade of diagnostic errors.
Plus, if you are in the end plate zone, the patient will usually let you know.
End plate noise is notoriously painful. Fibrillations themselves do not cause pain, though the needle insertion obviously does. The other distinguishing feature is the rhythm. End plate spikes fire irregularly.
Whereas fibrillations are like a metronome.
Exactly like a metronome, extremely regular.
Let us touch on the amplitude. We're generally looking at 20 to 200 microvolts for fibrillations.
The amplitude is directly correlated with the diameter of the muscle fiber. So as a denervated muscle atrophies over time, the fiber diameter shrinks, and the amplitude of the fibrillation potential proportionally decreases.
We should also discuss the grading scale. We all use it, but definitions can drift. The paper formalizes the 1+ to 4+ scale. What constitutes a strict 1+?
A1+ is defined as persistent fibrillation potentials in at least 2 areas of the muscle. It cannot be just a fleeting blip. It must be reproducible.
That is definitely a higher standard than some might use in a rushed clinic setting.
It is necessary for accuracy. Moving up the scale, a 2 plus means a moderate number of potentials in 3 or more areas.
And a 3 plus.
A 3 plus is a large number of potentials in all areas tested. A 4 plus is simply profuse, widespread activity that completely fills the baseline. It is impossible to miss.
When we see these, the clinical context is usually a neurogenic injury. We immediately think of radiculopathies or motor neuron disease involving axonal loss. But the authors warn us to keep our differential broad.
That is a very common trap to fall into. While it is often axonal loss, we can absolutely see fibrillations in myopathies.
The underlying mechanism is different in those cases, though.
It is. In a destructive process, like a necrotizing myopathy, you get muscle fiber splitting. A segment of the fiber becomes physically separated from the end plate zone.
So it loses the signal.
Exactly. It becomes functionally denervated, even though the nerve itself is completely intact. Because of that separation, it begins firing spontaneously.
The takeaway there is that the rain on the roof sound confirms fiber pathology, but it does not automatically differentiate between a primary nerve issue and a primary muscle issue. You need the full clinical picture.
Context is everything in electromyography.
Let us shift gears from the single muscle fiber to groups of fibers. We are moving from the rain to the misfiring motorboat, the complex repetitive discharges.
These are truly fascinating electrical phenomena. We are no longer talking about a single fiber acting independently. This is a group of muscle fibers discharging in near synchrony.
The mechanism is a phaptic spread. I often describe this to residents as a short circuit in the muscle tissue.
That is a perfect analogy. One fiber depolarizes spontaneously, but instead of that electrical current dissipating, it spreads directly to the adjacent fibers, forcing them to depolarize.
And it creates a loop.
It creates a reentry circuit. A variable number of neighboring fibers fire in a sequence until the circuit completes the loop and re-triggers the original fiber.
It is essentially the skeletal muscle equivalent of a cardiac arrhythmia.
That is a great way to think about it, and that mechanism dictates the sound you hear. Because it is a continuous loop, the frequency is highly regular, usually between 3 and 40 hertz.
But the onset and cessation are abrupt.
Extremely abrupt. It requires a specific threshold to initiate, and once that threshold is lost, it stops instantly. The machine runs perfectly, and then it just cuts dead.
Which gives us that characteristic misfiring motorboat or jackhammer sound. Visually, these waveforms are quite complex, polyphasic, or serrated.
They look complex because you are recording an entire group of fibers firing just slightly out of sync with one another.
The paper notes that complex repetitive discharges are nonspecific regarding etiology, which can be frustrating. However, they provide incredibly valuable temporal information.
They act as a chronometer for the disease process. You will almost never see complex repetitive discharges in an acute setting. It takes significant time for those aphaptic connections to form.
So their presence indicates a chronic condition.
Always. We see them in chronic radiculopathies, long-standing peripheral neuropathies, and slowly progressive myopathies.
If I see fibrillations alone, it could be acute. But if I see complex repetitive discharges, I know the pathology has been present for a while.
That is a very safe general rule to apply in the clinic.
Now, if we take that electrical instability and speed it up significantly, we arrive at the classic dive bomber sound, myotonic discharges.
The dive bomber is arguably the most famous sound in our field. It is generated by the waxing and waning of both the amplitude and the frequency of the discharge.
How exactly does this differ functionally from the complex repetitive discharge?
Complex repetitive discharges are stable. Once the motorboat starts, it runs at a fixed speed. Myotonic discharges are highly unstable. They constantly rev up and slow down.
And we are back down to the single fiber level with these, correct?
Correct. This is a membrane abnormality intrinsic to a single muscle fiber. The membrane is hyperirritable. If you insert the needle or even gently tap the muscle, it triggers a prolonged, repetitive run of firing.
The frequencies are much higher here.
Considerably higher. We routinely see frequencies between 40 and 100 hertz. That rapid firing is what produces the engine revving quality of the dive bomber.
Clinically, hearing that sound narrows the differential diagnosis quite sharply.
It absolutely does. The immediate thoughts are the myotonic dystrophies, type 1 and type 2, along with myotonia congenita.
But the paper cautions us against stopping there. We cannot miss the other associations.
Tunnel vision is dangerous here. Inflammatory myopathies, especially polymyositis, can generate myotonic discharges. We also have to consider metabolic conditions.
Acid maltase deficiency, or POMP disease, is a major one to remember.
It is, along with hyperkalemic periodic paralysis. Pompe disease is particularly important to keep in the differential for adult-onset cases where the presentation might be atypical.
It is a vital reminder that myotonic discharges describe the electrical waveform, not a specific genetic diagnosis.
Exactly. It is a finding, not the final answer.
Let us move further up the anatomical ladder. We have covered single fibers and groups of fibers. Now we must discuss the entire motor unit, fasciculations.
This is the finding that usually raises the anxiety level in the exam room for everyone involved. Fasciculation potentials are spontaneous discharges of a complete single motor unit.
Meaning the nerve fires and all the individual muscle fibers innervated by that nerve contract simultaneously.
Which is why, unlike a fibrillation, a fasciculation is often visible to the naked eye as a muscle twitch.
Physiologically, where is this originating?
Most commonly, it arises from spontaneous depolarization at the nerve terminal itself.
On the screen, these simply look like standard motor unit action potentials.
They can look completely normal. However, if they originate from a pathologic motor unit, one that has undergone damage and subsequent reinnervation, they can appear enlarged, complex, and polyphasic.
The critical feature that distinguishes them from voluntary motor unit firing is the firing pattern.
Irregularity is the defining hallmark. They fire at low frequencies, generally 1 to 2 hertz, but the interval between discharges is entirely unpredictable.
That irregularity produces the popcorn sound.
Or the sound of large raindrops on a tin roof. The paper applies the exact same 1+ to 4+ grading scale here.
And a 4+ fasciculation grade is quite severe.
It is defined as a frequency greater than 100 per minute. That is a profound amount of spontaneous activity.
This brings us to the most difficult question we face. You have a patient presenting with twitches. Is it benign fasciculation syndrome, or is it amyotrophic lateral sclerosis?
It is the heaviest question in the clinic. The authors remind us that fasciculations are exceptionally common in entirely healthy individuals.
We have all experienced an eyelid twitch after too much coffee or a calf twitch after exercise.
But they're also a primary indicator of anterior horn cell disease. The paper lists the severe pathologies associated with them, including reticulopathies, axonal peripheral neuropathies, spinal muscular atrophy, and amyotrophic lateral sclerosis.
How do we differentiate benign from pathologic based on the spontaneous activity alone?
The difficult truth is that you cannot diagnose amyotrophic lateral sclerosis based solely on fasciculations. You must look at the company they keep.
You are referring to the triad.
Exactly. If you see fasciculations occurring alone, it may very well be benign. The probability of it being a benign finding is strictly below 0.01 if you do not see any other abnormalities on a comprehensive exam. But if you see fasciculations plus fibrillation potentials plus neurogenic motor unit changes, the clinical picture is entirely different.
That triad significantly elevates the suspicion for motor neuron disease. The fasciculation is just one component.
It requires the full contextual analysis.
Before we move on from motor units, we need to discuss grouped firing. The paper outlines doublets, triplets, and multiplets.
This occurs when the motor unit essentially stutters. Instead of a single discharge, you capture a rapid burst of 2, 3, or more potentials.
This pattern has a very specific metabolic correlation that is easy to overlook.
Hypocalcemic tetany. If you observe multiplets during your exam, you absolutely must check the patient's calcium levels. It is a highly reliable correlation.
Let us transition to the rhythmic discharges. These are unmistakably distinct because they sound almost engineered. We will start with myokymia, the marching soldiers.
Myochemic discharges are a remarkable finding. These consist of repetitive bursts of spontaneously firing single motor unit action potentials.
How do we differentiate that from the complex repetitive discharges we discussed earlier?
In myokymia, it is the exact same motor unit firing repeatedly in a distinct burst. Complex repetitive discharges involve different fibers triggering one another in a loop.
Myokymia also has a very specific cadence.
It does. You see a burst of firing at 40 to 60 hertz, followed by a short period of absolute silence lasting anywhere from 0.1 to 10 seconds. Then the identical burst repeats.
Burst, pause, march, march, march.
That predictable cadence is why it is likened to marching soldiers.
Where do we typically encounter this clinically? It is not something we see every day.
It is quite rare, but when you do identify it, it is incredibly diagnostic. A classic etiology is radiation-induced nerve injury.
So if you are evaluating a patient with a plexopathy and a previous history of cancer radiation therapy, seeing myokymia is highly informative.
It strongly points toward radiation fibrosis rather than malignant tumor infiltration or idiopathic plexitis. That distinction completely alters the management strategy for the patient.
The paper also specifically details facial myokymia.
Facial myokymia is an entirely distinct clinical entity and generally carries a more serious prognosis. It is frequently associated with intrinsic brainstem lesions.
Such as multiple sclerosis plaques or pontine gliomas.
Correct. The paper also notes its presence in Guillain-Barré syndrome. Facial myokymia is observed in about 15% of Guillain-Barré syndrome cases.
That is a significant percentage to keep in mind, perhaps before coordinating treatments like IVIG.
It is usually an early, transient finding that resolves as the patient recovers from the acute phase of the syndrome.
Next on the list of rhythmic discharges is neuromyotonia. This finding sounds intense, and the underlying physiology is extreme.
It is very extreme. Neuromyotonic discharges involve motor axons firing at incredibly high frequencies. We are observing rates between 100 and 300 hertz.
That is dramatically faster than any other waveform we've covered today.
It is. The bursts often exhibit a decrementing pattern, meaning the amplitude visibly drops off as the burst continues because the nerve simply cannot sustain that level of output.
The sound is described as a high-pitched pinging noise, almost like submarine sonar.
That is a very accurate description of the audio.
And what is a clinical context for neuromyotonia?
It indicates peripheral nerve hyperexcitability. This is the defining feature of conditions such as Isaac's syndrome and Morvan syndrome,
The underlying issue is often channelopathic.
usually involving the potassium channels on the nerve membrane. They fail to repolarize properly, leaving the nerve in a state of continuous hyperexcitability, resulting in these rapid-fire discharges.
Finally, we need to address the distinction between cramps and rest tremor. Both can manifest as bursts of activity on the monitor.
Cramp potentials are involuntary, high-frequency discharges, typically running at 40 to 60 hertz. They recruit a massive area of the muscle and build up rapidly.
But the defining characteristic is how they terminate.
A cramp ends with a sputtering stop. It is a disorganized, messy cessation as the muscle slowly relaxes. It does not cut off cleanly like the motorboat sound of complex repetitive discharges.
Contrast that sputtering with a rest tremor, such as you would see in Parkinson's disease.
In a rest tremor, you observe rhythmic bursts of multiple different motor unit action potentials, separated by brief periods of silence.
The key is the morphologies of those spikes.
Exactly. A tremor burst involves a mixture of different units, so the spikes within the burst look morphologically different from one another. In myokymia, the burst consists of the exact same unit repeating, so every spike looks identical.
Identical spikes indicate myokymia. Mixed spikes indicate tremor. That is a brilliant practical rule.
It is a vital distinction to make during the exam.
We have covered a tremendous amount of ground and analyzed a symphony of pathology. Let us bring this back to the daily reality of the clinic. Why is mastering this so critical?
The analysis of spontaneous activity forms the absolute foundation of the entire electromyography study. You cannot accurately interpret the recruitment pattern or analyze the motor unit morphology if you have not first thoroughly assessed the spontaneous activity.
It provides the essential context.
It dictates the chronicity, the severity, and the precise localization of the lesion.
And accurately identifying these patterns directly dictates interprofessional patient care.
Absolutely. Distinguishing a myopathy from a neuropathy completely alters your diagnostic workup. Recognizing myokymia might spare a patient an invasive biopsy if their history aligns with radiation injury.
Or, conversely, identifying widespread fasciculations and fibrillations initiates a very different pathway.
It triggers the difficult process of managing a motor neuron disease like amyotrophic lateral sclerosis. At that point, the neurologist becomes the central coordinator for speech therapists, physical therapists, respiratory specialists, and palliative care.
The electromyography finding is the catalyst for that entire care network. Let us quickly recap the audio cheat sheet one final time.
Fibrillations sound like rain on the roof. Fasciculations sound like popcorn. Complex repetitive discharges sound like a misfiring motorboat.
Myotonic discharges are the dive bomber.
Myokymic discharges sound like marching soldiers. And neuromyotonic discharges produce a high-pitched pinging sound.
I promised a final provocative thought for our listeners to take away. The paper highlights a stunning anatomical correlation regarding facial myokymia that beautifully illustrates neuroanatomy.
It is one of those clinical correlations where the internal wiring explains the external presentation perfectly. The facial nerve nucleus is located in the lower dorsal pons. But the fibers do not exit the brainstem directly.
They take a significant detour.
They travel dorsally and form a loop around the abducens nerve nucleus, the sixth cranial nerve, before turning back to exit the brainstem ventrally.
That hairpin turn is known as the internal genu of the facial nerve.
Because of that specific loop, the facial nerve fibers are exposed within the brainstem for a much longer distance compared to other cranial nerves. This extended course renders them uniquely vulnerable to intrinsic pontine pathology.
So when you are performing an exam and you hear that marching soldier sound in the orbicularis oculi or the mentalis muscle, you're not simply documenting a peripheral twitch.
You are potentially listening to a lesion sitting deep within the pons. That specific sound is pointing directly to the millimeter of tissue where the facial nerve wraps around the sixth nerve nucleus.
It is the ability to map a central lesion based on a peripheral sound. That elegant deduction is the true art of the needle examination.
I completely agree. It is what makes the field so deeply engaging.
And that is a perfect place to conclude our discussion for today. Thank you all for joining us on this weekly neurology deep dive.
It has been a pleasure.
We look forward to guiding you through the literature again next time.